You can hear me, no?
Just now, sir.
Okay. Sure.
Am I audible, doctor?
Yeah. எனக்கு கொஞ்சம் ஸ்க்ரீன் ஷேரிங்கும் கொடுத்துருப்பா. முதல்ல பேசும்போது நான் ஸ்லைடு கொஞ்சம் காட்டணும்.
ஓ, உங்களுக்கு வேணுமா? ஓகே, ஐ ஜஸ்ட் அட்மிட் யூ. Yeah, I made you. Just check with the screen sharing.
வந்துச்சா?
Visible.
Oh. Okay.
Login.
Unmute.
Yes, can you hear me now?
Yeah.
Doctor, I made you the co-host. So if you'd like to share anything, you can share using the share screen option.
Are you recording? You started.
I started.
So you are recording. Okay, fine. You can record. And don't transfer. You can record afterwards. Already admitted.
Not a,
Ask them to.
just text them.
Neeraj, am I audible?
Yes, you can.
Yeah, sorry, I didn't realize I was muted. So, all well with you?
Yes, thank you. You're keeping well?
All good, thank you. You please meet Dr. Vishwanathan, a neurosurgeon on our team.
Hello.
Hi, hello.
You might have bumped into each other in the Madras Club, I'm not sure. When we had the colloquium.
Around.
I don't think we really met at that point. Yeah. Yeah.
So, so this is being a dialogue. We have nothing to no slides to share, do we, Neeraj?
I have made a few because my end of things to introduce the patient and the seriousness.
Sure.
I'll show some of the scans and stuff.
Sure. So that will be after we have the initial dialogue, then we open up for that presentation from you, and then we discuss a little further.
Sure, sir.
So Vaidya, you will, for the dialogue, you will stop everyone else's video. Is this from home, Neeraj?
I'm at home. Yeah, it's Saturday.
Yeah,
So
I can see from the curtains. I expect your office doesn't have these curtains, but yeah.
Unfortunately not.
Although you have a very nice office, large one at that.
Thank you.
So you're spending more time in your office now.
Yes. I'm spending a couple of days at St. George's a week and one day at my medical legal personal office and rest from
Right.
home. So
Wonderful.
yeah.
And when you get back to work, will it still be the same proportions?
Yeah, so we're carrying on with work. So work hasn't really stopped. Even our outpatient clinics, quite a lot of them can be video consultations, and the ward work, obviously, we have to go. So routine outpatient work is quite a lot of video consultations. So there's a specialist NHS platform for that, Attend Anywhere. Works quite well.
And this is a dedicated platform from the NHS.
That's right, and it's supposed to be secure and whatnot.
Right. And for the medical legal?
A good thing is Attend Anywhere. What you have is they come and wait in a waiting area.
Okay.
There's somebody who can help if patient have any question, and you
Right.
call them in like you would call them in from the waiting area to your consulting room.
Right. Right.
And there is facility for trainees to observe, etc. So there are a number of extra features which are not there in some of these Zoom-like softwares.
Yes. 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 It's been customized for the NHS.
That's right. So yeah, and medical legal, I think so far we've been doing video consultations as well for that.
Right.
And meeting with barristers, etc. Again, it's all mixture of platforms. It could be Zoom, it could be MS Teams, it could be
WebEx.
All sorts of things.
Yeah, I can imagine, because it depends on what the firm is using.
Absolutely, and we don't mind, you know, whatever for them.
Right.
But I think it's done quite good. Our experience has been very good. So one of the problems in NHS we had was lots of people do not attend.
Yeah.
With remote consultations, that has come down to nearly zero.
Yeah. Yeah.
And then you don't have to travel. Lots of costs are saved. Environment is saved. Why
So
not?
I was just telling Eileen Joyce yesterday, because we had a handover discussion,
Right.
and I was telling her that you know, the managers will be looking at opportunities to close down a few things now.
Yes.
Close down several things, in fact.
I think we'll probably carry on doing some work remotely.
Yeah.
Because it does help environment. It does probably save costs and hassle for patient.
Oh yes.
For traveling for more than an hour to come to our hospital, find parking. They don't have to do any of that.
In fact, I'll never forget, you know, Mary Robertson's Tourette clinic.
Yeah.
We had this person from the Orkney Islands who would come once in 6 months.
Right.
So was flown in a seaplane
Right.
to I think Edinburgh, and then would take the train to King's Cross, and then had a you know, a taxi bring her to Queen Square, and all this was for that 15-20 minutes of airtime, and then she'll go back. So
So save,
all that will become a distant memory now. And I can imagine the cost the NHS was bearing for that. So
We have people coming from, for example, Isle of Wight.
yeah,
So that there is a ferry to take on the sea and then take train or whatever else,
yeah.
for a consultation, maybe 20 minutes.
Exactly.
Uh, surgery we can't do remotely, I guess.
True. True.
Not yet, I suppose. Yeah.
Although
Soon the
Dr.
robots will
Vishwanathan
take
was,
over, I guess.
but you were saying, Dr. Vishwanathan, that you can adjust the neuromodulation remotely now, the DBS.
Yes, yes. So there's one of these companies that has allowed us to do this setting through the GPS, through if the telecommunication thing, if they have all the permissions. So the patient can be anywhere in the world and we could change that DBS setting.
How are we doing for time, Vaidya? 2 minutes to go.
Yes, sir.
So for the dialogue part, I think what you should do is switch off all other videos
Okay.
and switch off everyone else's audio as well. Yeah.
2 minutes, we can just start.
Yeah. I think you can go ahead and admit everyone, Vaidya. Vivek, can we admit everyone?
Yes, sir. I am admitting we are live on Facebook.
Okay. So good evening, everyone. For ease of communication, can I request everyone to switch off their videos so that you get better bandwidth as well for this part of the dialogue, and you can switch it back on when you want to ask a question. Very easy to brain and behavior, which really is actually the second in the series that we've done. The first one was on Alzheimer's, and we did it with another eminent Indian neuroscientist, Madhav Tambisetti, in the US, John Hopkins. And this time we have the equally eminent Dr. Neeraj Agarwal from St. George's Hospital in London. Welcome, Neeraj. Thank you so much for agreeing to do this.
Thank you. Thank you very much for inviting me.
I'm sure it's kind of postprandial time in London at this point in time. So I hope we don't put you to sleep. The brain and behavior dialogues are a way of talking about the links between brain and behavior. And today we are focusing on traumatic brain injury. And we're going to be talking about what happens to behavior after traumatic brain injury. And you might wonder why we are thinking so much about it. I'd just like to point out that it's one of the most important causes of problems in young people, because traumatic brain injuries often happen in road traffic accidents. As we know, that people like helmets, right? Bikes without helmets. That's one of the things. And just physical consequences are all severe and psychological. So with that, options of and I'm sure many of you being professionals will be very, very interested to know. I know that probably are some patient relatives who are concerned about the problem, who are also joining in, and we welcome everyone. Once again, may I request everyone who's not actively in the dialogue to switch off their video so that we can switch you back on when we come to the Q&A section of the dialogue. Neeraj, why don't you start by telling us a little bit about your training, what you did in India, when you left India, and your journey in UK. I think everyone will want to know this about you.
All right. Well, I'm born and brought up in India. I did my basic medical training from King George's Medical College in Lucknow, which is in Uttar Pradesh. And subsequently, I did my MD in psychiatry from All India Institute of Medical Sciences. And soon after that, whilst I was doing a senior residency, I moved to UK, and I trained at St. George's Hospital Training Rotation, and subsequently at Charing Cross, also at National Hospital, Queen Square. And I did a number of other placements with eminent neuropsychiatrists in London. And now I've been working and running the regional neuropsychiatry service at St. George's for the last 17 years.
Wonderful to have that little update of your very inspiring journey. And I'm sure many young people will be inspired to want to follow in similar footsteps after today's dialogue. Dr. Agarwal and I, we met at Queen Square when we were both training. And so we've known each other for some years now, and we now collaborate as part of the International Neuropsychiatric Association. So it's great to be having you here today, Neeraj. Let me start by asking you, what happens to the brain after a head injury? When someone has a traumatic brain injury, what happens to the brain?
That's a very interesting question. And if we take a traditional look, we used to be worried about the initial neurosurgical complications after a brain injury. So we would be concerned about a direct impact injury leading on to either fracture of skull, which could be depressed skull fracture, or collection of blood underneath the skull in the membranes around the brain, like subdural hemorrhage or subarachnoid extradural hemorrhage. And there can be further direct impact injuries, including contusions in various parts of the brain. We used to talk about coup contra coup injuries, which are on the site of the impact or on the opposite side, diagonally opposite side of the brain. But we became more and more aware of other mechanisms, including rotational forces, including the relative movement between different parts of brain. So for example, gray matter and white matter have different consistency and density. So as a consequence, they can move at slightly different rate when there is a significant impact on the brain. And as a consequence, they can be shear stresses, shear injuries, diffuse axonal injury. And there are then a number of other secondary mechanisms, including increase in intracranial pressure or changes in neurochemicals or neurophysiological structures, including development of post-traumatic epilepsy, infections. So those are very much the secondary consequences. But the real mechanisms are either the direct impact on the brain or the relative movement of different parts of the brain against each other, leading on to shear stress.
So how you get hit, where you get hit, and how severe the blow is, and all this can determine what happens to your gray matter, what happens to your white matter, what happens in terms of fluid collection or blood collection in various parts of the brain, and so on. So it's quite complex. It's not a simple thing.
Absolutely. So the severity of impact, but also secondary rotational forces, which could be quite relevant. So for example, you talked about earlier helmet, and I think that's so important, particularly for motorbikes, and they are becoming faster and more powerful as we go along. Roads are getting better, so people are driving and riding faster. So I think having those helmets can protect against some of the impact injury, but they may not protect against further rotational forces and the relative movement between gray and white matter, for example. But still, I think they protect you against very significant impact injuries.
So safe riding is important. Wearing a helmet is important.
Absolutely.
These precautions are strongly recommended, aren't they?
Absolutely. And similarly, driving, I think one of the biggest protective factor is wearing a seat belt. And I remember growing up in India, we didn't have seat belts, and we started to put on seat belts. And even now, what is quite commonly I see is seat belts are mandatory in front, but not at the back. And really, I would urge people to start making sure that you have seat belts at the back as well. And I have known cases where somebody who was not wearing seat belt in the back seat has straight away gone through the front windscreen, gone on the road, and had a very, very serious injury. So I'm not trying to scare people, but I'm trying to highlight that the biggest protective factor in the car is the seat belt.
And isn't it true that a person immediately after the injury might black out briefly, wake up and seem okay, but actually there's something going on inside the brain like an extradural hematoma, which then they are then much worse a little later. So even a short blackout should not be ignored. Would you say that?
Absolutely. I think that's a very important point. So generally, people would get confused straight away after brain injury, and they might, in more severe end, they might get comatose, or they might be behaving abnormally. But in some people, initially, they might seem completely all right. And they might get up and try and get back in their car or motorbike or try and go home. But they can then show deterioration because the bleeding has gradually accumulated and has compressed the brain and started to affect the functions of the brain. So it's very important to continue to observe at least for the first day. Sometimes it could be even slower than that, but at least if somebody is not showing any symptoms for first day or two, then generally they are okay. I think ideally they should seek help if there is a significant impact on their brain. And they can have nowadays various brain scans, CT brain scan or MRI brain scan, depending on what the problem is and kind of injury, they can determine whether there is any buildup of or development of intracranial hemorrhage.
we're all used to thinking that you get hit on the head in some way and you get paralyzed. But we think less often in society about the cognitive and behavior problems that follow. Could you tell us a little bit about the cognitive and behavior problems that you commonly see after a head injury?
That's something we are now seeing more and more. And I think you're absolutely right. If we look back 20, 30 years ago, quite often people with very serious brain injuries would have died on the scene or would have died soon after because the emergency services, brain scans, neurosurgical techniques, transport to hospital, all of those factors were not as good. So people didn't have good access to care early on. But with development of technology, imaging technology, with neurosurgical techniques, with early management in ITU, but also quick transport, I think that's the key. Quick transport from the site of injury to a good hospital has led on to greater survival. So people with more serious brain injuries are now surviving. And in the olden days, main focus was on neurological consequences, like you mentioned about paralysis, sensory problems, sometimes audiovestibular problems like dizziness or tinnitus. But increasingly, people recognize quite often the most disabling problems are neurocognitive difficulties, like difficulties with attention, concentration, memory, other higher brain functions, frontal lobe executive functions, which could have consequences on day-to-day function, but also our work, whatever work we used to do. And in addition, a whole range of psychological and behavioral problems like low mood, depression, significant anxiety, post-traumatic stress disorder, behavioral problems like irritability, anger, aggression, impulsivity, all of those can be quite disabling and have significant impact on not only on the person, but their families.
And this could go on for quite some time after a head injury?
That depends on the kind, nature, and severity of brain injury, but quite often brain injury can result in lifelong changes in emotions and behavior, particularly if they haven't been appropriately addressed early on. So if people did not get appropriate help and support, multidisciplinary care, neurorehabilitation early on after the injury, they are more likely to have more persistent problems.
Right. And you're saying that some of these problems could stay with them for the rest of their lives. So presumably they are then dependent on family for help and support and guidance.
Absolutely. But idea during the rehabilitation process also is to help them learn various compensatory strategies, various strategies that they could use to manage it themselves and be slightly less dependent on others. That might mean that they are also able to carry on doing their work, depending on the nature of their work.
Right. So rehabilitation becomes important.
Rehabilitation is very, very crucial. And it's not just a few days or weeks early on, which could be more intensive rehabilitation as an inpatient after the initial hospital stay. But quite a lot of rehabilitation can happen at home once people have gone back to their home with involvement of appropriate experts, which could include neuropsychiatrists, neuropsychologists, occupational therapists, and other multidisciplinary clinicians, depending on the nature of the symptoms.
And could you describe if someone with a serious traumatic brain injury after a road traffic accident comes into your unit, from say the ICU period we'll leave alone because that's neurosurgical management. But once they've gone past that period and they are now, really entering rehabilitation, could you describe the journey? I mean, what happens? What do you address at each stage? How long does it take? Roughly, just so people understand.
So we have the regional trauma pathway at St. George's. So we have right on top of the A&E department helipad for people to be flown straight away from the site of the accident, which could be 50 miles away, but they can come pretty quickly with the helicopters. They're taken into A&E. They have a very quick assessment. Quite often that assessment and much of initial management, including medications, pain relief, intubation, may have happened in ambulance. And once they come in, obviously, depending again on nature and severity of injury, and we're talking about more severe end of the spectrum at the moment, where they may need urgent neurosurgical intervention to remove clots in the brain, either in the brain membranes or inside the brain parenchyma. They may remain in ITU, and we get involved from that stage, really. You know, we help advise our colleagues on behavioral management, particularly as soon as sedation is reduced and people are extubated. They might become very impulsive. They might want to get out of bed, move, pull out their tubes, and that could hamper their treatment. So we help manage some of those behavioral problems. Subsequently, when they come out of ITU, they go into acute trauma wards, and they might be in what we call post-traumatic amnesia, where people may not have much insight and awareness. They think they are fine. They have no recollection of the actual injury. And this is particularly problematic in younger people who might be at work. All they remember is they were at work yesterday. Today I have to go to work. Why I'm here in hospital. And the other issue with brain injury is that quite often you can't see any scars. Even if the neurosurgical intervention took place, the scar might be on top of your head or back of your head. You may not be able to see anything in the mirror. Everything looks fine. You don't feel any particular pain unless there are other bony injuries. So people think they're fine, but they might show a range of neurocognitive and neurobehavioral problems. They might be disorientated, confused, may not have any recollection of day-to-day events, may not recognize family members, and then they may have a whole range of behavioral problems, impulsivity, irritability, aggression, which could interfere with the further treatment. So we help manage some of those. And once that phase is over, then they go to what inpatient, 12 weeks inpatient neurorehabilitative treatment, where everything is assessed in great detail, goals are agreed with the individual, they have a copy of the document, and everybody works in tandem. So a whole range of specialists, including physiotherapist, occupational therapist, to psychologists and neuropsychiatrists, we all work together to help bring their functioning back, help improve their symptoms, a whole range of emotional and behavioral and physical symptoms back to normal. And once they are discharged from then on, they have access to community neurorehabilitation services, which are normally done on outpatient basis, where people would come and see us time and again over a period of time, depending on how long the symptoms are.
And does the team have a leader, sort of someone who conducts the orchestra?
Absolutely. So everybody would have a what we call case manager. Or they could be a chairperson of their care, who would be coordinating the meeting or dialogue between various clinicians. And they are very key people because they work very closely with the individual, and they are quite often the first port of call if the patient thinks something is not right. And that reduces patients' worry about who to contact if I have a particular problem.
The connection between the cognitive deficits and the behaviors, are these connected? I mean, can you predict based on the cognitive deficits that these are the behaviors, or vice versa?
There is very often a connection between the two in two different ways. One is based on the direct organic anatomical correlates. So for example, if somebody had injury to front lobes of the brain, then we know there would be certain kind of neurocognitive impairments seen in those individuals. They could be problems in planning, their judgment, their ability to see the consequences of their actions. They may not be able to organize things or judge certain elements. But at the same time, those individuals are more likely to have a range of other emotional and behavioral problems, particularly emotional lability, impulsivity, irritability, aggression. They are more likely to have mood problems as well. So that's one particular element. So for example, injury to temporal lobe, we know they're going to be very prominent memory problems. But at the same time, they're more likely to have certain language problems, certain behavioral problems. The second element of this correlation is in relation to the nature of neurocognitive impairments. So how disabling, how difficult those neurocognitive difficulties are could lead on to a range of emotional and behavioral problems. For example, people might be frustrated about day-to-day memory problem. People might feel despondent. People might get low, sad, or depressed. They might lose hope about future. So there can be psychological reactions to the neurocognitive impairment that people can experience.
Right. So they need help for both these reactive problems as well as the more organic problems that follow brain injury.
Absolutely. And they have to be appropriately assessed through a detailed neurocognitive assessment to establish whether, and also a full assessment, including brain scans and all sorts of other assessments to establish what is the nature of the injury, what are the neurocognitive impairment, and whether those behavioral problems are a psychological reaction to the situation or they are directly caused by the actual injury itself.
So we have a question from Asha Thakkar who wants to know what the medical treatment is, by which I presume the drug treatment is for the behaviors, for the cognition. Would you like to describe, and then mild and severe also?
Absolutely, that's a good question. So I think everything should be a part of overall larger multidisciplinary effort. But medical treatment is mainly based on establishing what is the main problem. So there can be a range of different issues. So very early on, quite often the medical management is focused on managing the increased intracranial pressure. So our neurosurgical colleagues, our intensive care colleagues would be working on managing the intracranial pressure. They would be also managing the consciousness level to try and keep people sedated whilst managing some of the acute problems. Subsequently, medical management depends on the nature of problems. So for example, somebody who has completely poor sleep-wakefulness cycle, they are not sleeping at all, they are not settling. And if they are not resting, the brain is not going to heal. So they may need help with sleep. People may need help with pain management. People may need help with anxiety, with agitation, with low mood, with emotional lability, impulsivity. So depending on what is the kind of problem, we need specific medical management for that. So early on, quite often people are on several medications, but gradually we try and reduce medications as far as possible as things start to settle.
And so in a sense, you would use anxiolytic drugs, sedatives, antidepressants, antipsychotics, mood stabilizers as appropriate for the individual.
Absolutely, all of them. I think very wide range of medications are used. More recently, there are newer classes of medications which are being used. That includes psychostimulants, medications like methylphenidate to stimulate the brain. So quite often people used to try and sedate the brain in order to control the behavioral problems. And more recently, there is a focus on stimulating the brain to help regain the normal functions of the brain, and that could help managing the behavioral problems. But again, it depends on specific assessment by the specialist team and the nature of problem.
In the last decade, there's been quite a bit of interest in mild or minimal brain injuries and the consequences of that. Would you like to tell us a little bit about that?
So that's one of the areas which has become controversial, but has gained more and more prominent. Interestingly, about 75 to 80% of brain injuries are mild. So it is the commonest form of a traumatic brain injury. Traditional understanding was that a vast majority of individuals who have mild injuries, and in some ways, I would put to you all that we all in our lifetimes end up having some very mild injuries to brain, right from a child falling whilst they're beginning to learn to walk, to somebody, suddenly accidentally knocking a head against a table or a door frame, so we all end up having these minor knocks to our brain, in our lifetimes. But quite most of the times we don't have any symptoms or very minimal symptoms for a short period of time. But even with more significant end of the mild traumatic brain injury, generally, luckily, most of the individuals would start to improve within first few days, weeks, and 60 to 70% of people are fully recovered from it within first 3 months. But some people, about 10 to 15% of individuals can have more persistent symptoms even 1 year after the mild traumatic brain injury. So seemingly mild injury can also have problems which are persistent and quite significant, really. And the symptoms are a range of physical, neurocognitive, and neuropsychiatric symptoms. So physical symptoms could be simple things like sensitivity to light or sound, or dizziness, or tinnitus, or headaches. They can be more neurocognitive problems with attention, concentration, memory problems, fatigue. There can be more emotional problems with increased emotionality, irritability, anger, or low mood and anxiety affecting their sleep. But it all affects day-to-day functioning. People can't do what they wanted to do. So even seemingly mild injuries can be quite significant.
And how often do you clinically feel this is psychosomatic? And how do you make that differentiation that these symptoms are organic versus psychosomatic?
It could be very, very difficult to tease out in vast majority of cases. And my experience is there is always a combination of two. And that is very much consistent with any other illness that we have. So we always, whether it's a neurological problem or cardiac problem or any other problem really in our lives, we all respond to our health differently. We have, and how much it affects us. So it's no surprise that somebody who has a mild traumatic brain injury can have different level of distress. Interestingly, people who have mild traumatic brain injury are more likely to remember the impact of the injury and the immediate circumstances. So they are more likely to have conditions like post-traumatic stress disorder, which can have overlap, not only overlap in the symptomatology with mild traumatic brain injury, but two together, they're more likely to be persistent and more likely to be causing more significant distress. So it's natural to have psychological reaction to mild traumatic brain injuries. And it is understandable that those psychological reactions then could lead on to worsening of symptoms. And for us, what is important is to try and recognize what is leading on to the symptoms and what's the best way to reduce the patient's symptoms, their distress, and improve their quality of life and functioning.
And in your view, what kind of a role does the pre-morbid status of the individual have to play in outcome? And a link to that, who does well and who doesn't do well after head injury?
That's a very good question, because quite often we forget, the individual behind the injury. As doctors, whenever we are looking at any particular illness, we shouldn't just be treating the illness. We should be treating the individual who has the illness. And part of that is their past history, their pre-morbid personality. So looking at whether they had any previous history of any mood problems, neurological problems, any ongoing problems, any other physical health problems, which could have an impact on how they present with symptoms afterwards. So people who have pre-existing psychological or psychiatric problems are more likely those problems after brain injury. But people who have other conditions, so for example, somebody may have endocrinal problems like thyroid, or a neurological conditions like epilepsy or stroke, they would be affected differently by a brain injury. So all of those things are very, very relevant. Other thing which is quite relevant pre-morbidly, perhaps less so in India, I guess, at the moment, would be alcohol and drug use. So that could be quite relevant. Unfortunately, a number of people, particularly young individuals who have road traffic accidents, are under influence of substances, some alcohol or drugs. And their long-term prognosis could be affected by that. And certainly, unless it's managed appropriately, they are more likely to have persistent and significant problems.
Interestingly, I think alcohol and drugs are becoming common as a causative factor or as an allied factor in India. A very interesting point made by Saras Bhaskar, who is one of our very prominent counselors and psychologists in Chennai. She points out that many of her patients with traumatic brain injury are victims of domestic violence, which, so we keep talking about road traffic accidents. We shouldn't forget there are so many other causes of.
So my apologies for that. I think that's a very, very good point. I think we have to look at a number of other assaults. So there can be assaults. Assaults could be during domestic violence, or there could be some kind of conflict outside home. So where people are struck by something, it could be a plank of wood, or it could be anything really. The other major cause of head injury, particularly in elderly population, is falls. So people with dementia, stroke, or other neurological conditions like Parkinson's, or generally, just somebody who's frail, somebody had flu or acute infection, and they could be confused. They get up to go to toilet in the middle of night and end up having a big fall, resulting in a head injury. So all of those, and I haven't talked about non-traumatic causes of brain injury, and we haven't talked about a big cause of brain injury, which is a very big separate area we are not going to cover today, is the blast injuries. So unfortunately, conflict and the war zones are common, and terrorism. So we do come across those cases as well, where people had a big blast injury. So it's not just road traffic accidents, but unfortunately in Western world, I think that's the biggest cause. And I think that will become a big cause in India as well, as we're going to have a lot better roads, or dual carriageways where the speeds are increasing and the cars are improving. So although cars are improving, we are driving faster. The chances of collisions are increasing as well.
I know you do a lot of medical legal work. So the links between clinical and medical legal, are there things that are more likely to become medical legal?
So it's very interesting. I think one of the areas which I think are lagging behind in India is how do we compensate people who have traumatic brain injury? So correct me if I'm wrong, I've been away from India for a while. I haven't insured my car in India, but my understanding was in India, a car was insured not the individual. So we will buy a car and that car is insured, and anybody would drive that car, the car is insured. In Western world, in Europe, in UK, United States, actually the insurance is car and the individual. So a particular individual is insured. And the difference is, as a consequence, if I see somebody who had a serious road traffic accident, they had, as a consequence, required significant length of treatment, care, they required, they couldn't do work. All of those things are compensated adequately through their car insurance. Whereas in India, I think it covers the damage to the car, but that quite often is the smallest part of the whole damage. The biggest damage is the individual. And I think that's not adequately. I'm sure that's going to change. I'm not sure whether it's already beginning to change. Is it still the same, or has that changed?
I don't believe it has changed very much. You, as a person, you're insured differently from your car. And you're right, the car is insured as a car.
Right.
And anyone can drive it. So yes, as far as I know, it's not changed.
So in Europe and United States, the biggest element, and I'm sure it's the same in Canada and Australia, New Zealand, etc. as well. So the big part of medical legal case, which happens almost invariably, is to ensure what is the nature of injury, whether the individual is going to recover, how much they're going to recover, how much care they need, how long they can't work. And I think establishing all that becomes very important, because everything has to be then financially compensated for
right.
during the medical legal case. So I get involved in those cases, and I think we are advising the judge on those matters. The judge wants expert opinion. So there are very detailed reports to highlight those questions.
Living as you do in one of the most multicultural cities in the world, are there cross-cultural lessons your work is teaching you?
I think it does, I think, in all sorts of ways. Certain cultures or certain people living in certain ways can be more prone to have certain kind of injuries. So some people might be taking more risks from certain cultures and get involved in more serious injuries or motorbike injuries versus car injuries. There can be pre-existing problems. So you talk about, their pre-morbid status. That could be different. But importantly, how people seek help after the brain injury is quite often determined by their cultural background. Certain cultures, they don't identify those symptoms as well early on and present quite later on. So I think all of those factors color what we can or cannot do. And we are very aware. I think we have to do a lot more educational work with certain individuals from certain backgrounds to work with them, to help them understand that this is more serious than that they think.
And I know that you're working at the cutting edge, and you're at a really excellent unit. What do you think are the burning questions that research is trying to answer about this whole area of brain injury and behavior? The most exciting things.
We are just beginning to understand the long-term consequences of brain injury. There's quite a lot of work going on in understanding mild traumatic injury. You earlier mentioned about the controversy behind it. So people have begun to do quite a lot of long-term cohort studies. So there's quite a lot of work going on in sport-related concussions. So for example, people may have, lots of Indian people follow cricket. I follow cricket. Cricket has been quite late to understand the consequences of concussion. So now we have concussion substitute, whereas previously people who fell down and banged their head, on the pitch, or they had a ball hit their head, they used to carry on playing. And that is particularly recognized in American football, rugby in United Kingdom, and it's now very common in football. There have been cases where in Football World Cup, one of the players, was concussed, and he kept roaming around, and he ended up asking just before the halftime with the referee You know, is that World Cup final ref? And referee thought he was joking, but actually he was completely concussed and confused, and he was not effective player at all. And the team was playing with 10 players rather than 11. So there's quite a bit of work going on in American schools where every child, secondary school child, at the beginning of year, they go through very detailed evaluation. And then they are assessed after each and every concussion. So hockey or any impact contact sport, even if the most minor of the concussion. And so there's quite a bit of work around those areas. There's quite a bit of work around neuroimaging and long-term consequences. So we used to think traditionally that brain injury is a static one-off condition. So generally we'll have a brain injury, there might be reduction in our brain functions and cause symptom, and gradually there would be a trajectory towards improvement. We are now recognizing that probably that's not true. There can be triggering of long-term cascades and neuronal loss, where people can develop late onset dementias, people can have decline, secondary decline. There's work going on various medications that we can use to treat different kind of symptoms. And there are studies about biomarkers. I think it's again one of the exciting area. Again, answering your earlier question about how do we differentiate between biological part of presentation versus psychosomatic or psychological elements. I think brain biomarkers would help us understand in more detail the nature of the brain injury and the real consequences of that versus psychological consequences. So yeah, it's an exciting field. We are only beginning to understand brain injuries, and there will be a lot more greater understandings in the future.
Very exciting, very exciting. I'm just going to take a few quick questions from people in the chat section before we go to the next part of the program. Dr. Venkateshwara wants to know, is there a golden hour for the head injury, just like the golden hour for the stroke, to get to hospital, of course?
I think it's probably not as important as in stroke, because in stroke, you're trying to reverse the blockage of brain artery before the brain dies. So that window of 4 hours, or in fact, even, well, shorter that window, better it is. I think as a rule of thumb, I think even in brain injuries, we are trying to get people as soon as possible. And this could be important, particularly in cases where there is a very significant increase in intracranial tension, which could be life-threatening. And unless that is managed either through surgical decompression or through, just general medical management, that could be life-threatening. So yes, as a rule of thumb, we want people to get into hospital as soon as possible, but that window is not as determined by, as in stroke, as in brain injury.
The question on neuropsychological management and how effective it is.
Neuropsychological management is quite important in people with brain injury, right from mild end of the spectrum to more severe end of the spectrum. And biggest part of neuropsychological involvement would be doing, first of all, a very detailed evaluation to establish the nature of cognitive impairments. And part of that is helping to understand psychological reactions, frustrations, mood, etc. And once those things are established, then they are a very important part of multidisciplinary team to work with individual to deal with those symptoms as we go along, help people understand and manage their neurocognitive difficulties as well, helping them understand compensatory strategies.
And another very interesting question about children. When children have traumatic brain injuries, does it impede their development and, the cognitive and behavior consequences?
This is a very good question. And this is, if you look at the rates of brain injury, and if you plot across the lifespan, there are two peaks. One peak is during the childhood and in the teenage years. And the second peak is in old age. So childhood is a common time for people to have brain injury. And brain injuries could have two completely different trajectories in childhood. After brain injury, people can have two completely different trajectories. So some people can have what we call a stall in their development. So their development is slowed or stopped. As a consequence, they fall behind their peers and they do poorly. And some of those difficulties become more and more apparent as the years go by. So once they go into secondary school, once they do 10+2 education or early university education, as the challenges, demands are increased, their deficits become more and more apparent. And they might, as a consequence, show more emotional problems and more behavioral problems. On the other hand, some children show remarkable neuroplasticity. The brain heals. So some of the children can do remarkably well, even after a very serious brain injury. But generally what I get to see, probably it's a selection in some ways, because people who do better, we may not see them as often in our clinic, so we may not remember them as much. But we tend to see more often people who have more significant and persistent problems. But what we do see is a very large number of children would have problems which become more prominent, more apparent as the years go by.
Thank you, Neeraj, for a lot of wisdom. I'm going to ask you, obviously, to stay on with us and comment and help us with the next section of the program. What we are doing is sharing a case study of a difficult to manage patient who has done well with multidisciplinary rehabilitation. And to start that off, I'm going to invite Dr. Vishwanathan, the neurosurgeon, who took in patient Mr. R the first time and who looked after him initially for his neurosurgical needs. Dr. Vishwanathan.
Thank you, sir. So, and thanks to the enthusiastic participation during this day of Vinayaka Chaturthi as well. Is everybody able to see my screen?
Yes, sir.
Thank you. So, Mr. R was a 38-year-old high-functioning executive who had returned incidentally from the UK to take up a new challenging job here, and he was traveling from Chennai down south when he met with a high-velocity road traffic accident. His car hit against a lorry, and he lost consciousness immediately thereafter. He had severe bleeding from his nose. He was treated at a local hospital, immediately intubated and ventilated. They sutured a rather long gash in his frontal region. And then he was brought to Ramchandra Hospital, which is the tertiary care hospital that I work in. Now, just to give an idea, this is the kind of injury that he had. You can see here that there's a significant depressed fracture, and underlying that fracture, there is a contusion in the frontal lobe of his brain, and also there's a contraco injury in the opposite occipital lobe and bilateral basifrontal contusions as well. So this sort of significant injury required surgery, and you can see that the jigsaw puzzle has been sort of fixed with a lot of these plates. The oral and maxillofacial colleagues also fixed his broken zygomatic bone. From the surgical standpoint, he recovered quite well. There were no surgical complications as such. But then he became increasingly difficult to manage from our neurosurgical point of view, and we had to get our in-house psychiatric team involved. He became extremely aggressive, talking irrelevantly. At some point, probably because of the occipital contusion, we couldn't even get a good eye contact with him. We were wondering whether that is a manifestation of his neuropsychiatric problem or an organic vision problem. He had only a very minor improvement from his neuropsychiatric issues. And thereafter, after staying for about a month in hospital, I basically handed over this crying baby, which we couldn't manage, to Professor ESK's hand. So this is where we are. Even the removing the sutures, our team couldn't do. One of his close friends, a plastic surgeon, he had to come there and he removed his sutures and things like that. And our nurses in our ITU still remember him for all the choicest words that he could use every day with them. So that's the neurosurgical angle. And now I think we'll know how the crying baby was pacified and improved.
So I'm going to request, thank you, Dr. Vishwanathan. I'm going to ask Dr. Rama to tell us what she did with the crying baby and how things progressed.
Good evening. This patient came to us a little short of a month of being hospitalized. So he was transferred straight from the other hospital from Dr. Vishwanathan's care. That was exactly a year ago. And the primary complaints that were reported by the family were sleep disturbances and severe agitation, aggression directed towards the family. And he was extremely restless, and he had paranoid delusions that people were out to kill him. And there were visual hallucinations about snakes. And he used to pick invisible threads from the air. The speech was irrelevant and incoherent, and there was a lot of emotional lability. He used to start crying without any reason. He had difficulty in eating food in his mouth. It appeared that he didn't know how to swallow it. And physically, there were problems with balance and walking. He needed support and supervision. And there was a history of frequent falls. And on top of that, there was urinary incontinence with a lot of severe constipation. So this was the profile of complaints he came with. So you can see that every system seemed to be impacted, and this was very distressing. Especially behaviorally, I think it was extremely distressing to the family because they didn't know how to manage him. As is the norm with Buddhi Clinic, we do a comprehensive 360-degree evaluation. So when he came into hospital, so we got to work. So we had the physician looking at him, and then we had the physiotherapist, we had the psychologist looking at him, we had the speech and language pathologist, and then we had the CAM physicians, that is the complementary and alternative physicians, the Ayurveda and naturopathy doctors. And we did the electrophysiology, the EEG, and we did all the blood work. And we also found that he had urosepsis. So there were other things happening alongside whatever other complaints he had. So, and our reports were all reviewed by Dr. ESK, who was the primary neuropsychiatrist and physician. So I think the first thing we did was looking at his medicines. We also understood that several of the neuroleptics which are being used to help his behavior were actually worsening him. So those were rationalized and changed. And initially on, he also developed a neuroleptic malignant syndrome. So many of the neuroleptics had to be pulled out, and then he was treated with haloperidol and phenergan, small doses, and we took him along. And there were other supplements which were put in. And he was also treated with sodium valproate and with piracetam to help with his brain function, with his behavior. And alongside the medication, we put together a therapy program, which was based on the assessment, which was physically, like I said, a lot of imbalance, posturally, rigidity in all the limbs. And in the clinical interview, there was significant caseness, especially in all the behavioral domains, anxiety, depression, sleep. And the NPI also picked up high scores on all these domains. And the cognitive assessment, we had a problem doing it initially in the hospital because he was very uncooperative and he was confused and disoriented. So we kept that for later. And based on whatever we had at hand, we put him on a therapy program. So initially it was about building rapport with the family and with the patient, especially the family, like I said, was very distressed, and settling him down for the diagnosis that we had of a post-TBI delirium. So rationalizing his meds and monitoring. And then the therapy per se was focused on the active therapies, catching him when he was awake and when he was cooperative. So we had little windows. So as we started working with him, we realized that there were parts of the day where he'd cooperate with the physical therapies, the physiotherapy where we worked on the gait and the balance and all that, and the psychological interventions where we were trying to establish a rapport with him, talk to him when he was more lucid, and the passive therapies, which were the CAM therapies, where we did acupressure and reflexology, which were the most appropriate then, and those focused on his sleep cycle, on his appetite, on his behavior, calming him down, etc. So those we used to do when he was sleeping. So we found these windows of time when we could work, when we could do around a couple of hours of therapy every day. So he was in hospital for around 25 days. And somewhere in between, maybe from the 15th day onwards, he kind of settled down. And for the delirium, we also looked at other causes, like maybe viral infections, etc. So we did the lumbar puncture. So it was very well worked up, looking at all the other causes which could be treated. So I think diagnostically also we were in a good place. And he gradually started settling down with all the rationalization of medication and became more cooperative for therapies. Initially, we had to restrain him. He wanted to run away. He was restless. But then as we went along, all these things settled down. I think there were little improvements. I wouldn't say they're very drastic, but we were able to treat everything else like the urosepsis, and we were able to make an impact on sleep and on the digestion, on the intake, food intake, on the gait, balance, etc. So there were incremental improvements that we observed up to discharge. Yeah. So that was the hospitalization. We did about 40 hours of therapy in about 25 days. That's what we did. Yeah.
And of course, I think what Rama did not mention perhaps is that for us, therapy, apart from physical therapy and psychological therapy, includes a range of holistic interventions. So all our patients receive acupressure and Ayurveda and other naturopathic treatments and so on. We find that they help our patients greatly. One pharmacological lesson I thought I would share from my experience and take Dr. Agarwal's feedback on this. All my neurosurgical colleagues and neurological colleagues like levetiracetam. I am rather worried about levetiracetam when it's given to brain injured people. And I often am forced to change it to sodium valproate or to topiramate. I wanted to check your experience on this.
I think that's a very interesting point. I think the reason why levetiracetam is used by neurosurgical colleagues or neurologists acutely is that there is increased risk of epilepsy or epileptic seizures after a brain injury. And quite often these are used prophylactically to prevent seizures developing. And levetiracetam, although being a new medication, it's the easiest to titrate in such circumstances. So whilst a while ago, before levetiracetam was there, we used to use other medications, we have moved on to this. But we also recognize that it causes huge number of psychological and behavioral problems, particularly depression, irritability, and aggression, which are the symptoms of brain injury, and more likely in more serious brain injuries. So I, likewise, like you, I have to work with individuals to move them on from Keppra to more relevant, more appropriate anti-epileptic drugs. Some people, depending on the risks, may be better enough to take them off. Some people, we have to move them on to a different anti-epileptic drug.
Thank you. I'm glad that we have a shared cross, what shall I say, national experience. I'm going to ask Vivek from our team to describe briefly the neuromodulation work he did with Mr. R to help his behavior.
Good evening, everyone. So like, as we have discussed so far about the traumatic brain injury, so I have one of the image to share, and this is this. If we are looking that what a traumatic brain injury can cause, and here we see, so there can be a cognitive disturbances, what we have seen in the patient. We are looking for emotional disturbances, behavioral and physical. And if we see like where our patient, Mr. R, lies, And I think it is on the yellow and the red mark and going for the green. So it is, if we see it, if I have to summarize all the neurocognitive symptoms, it is just right there. And when I have visited Mr. R when he was in the hospital, and we saw, okay, what we can do it to, just calm him down, where he can be less agitated, can be focused. And one of the other things, he had memory disturbances where he was unable to recognize near family members also. So the approaches we at Buddhi Clinic, we use neuromodulation like RTMS, repetitive transcranial magnetic stimulation, as well as transcranial direct current stimulation. And then we go around, then I have a word with Dr. Vishwanathan and find out, like, can we go for a TMS because it's a magnetic pulse, and whether his implants will allow us, and what is his state to sit at, like, same position for more than 40 minutes. And then we figure it out that I think the TDCS will be a better option for Mr. R. And in the initial phase, we did around 20 sessions. So it's daily sessions. We did 6 sessions per week, and we went around for like around 4 weeks for the first phase. And when it was going through and he was undergoing the psychotherapy regime, we find him, like, he is better oriented. His concentration and memory is getting better. And the best part was his irritability and rage. Like, so he was not as agitated or irritable over the course of therapy when we are doing the TDCS for him. And this also been corroborated with the neuropsychiatric inventory scores, that over at baseline we have done an NPI, and after 10 sessions, and we repeated after 20 and after 25 sessions, and there is a significant drop on his NPI scores. So I think going for a neuromodulation technique also helped him, what we can look for. So I think there is, apart from the generic, the conventional treatment and IM, I think the neuromodulation have benefited. Like, we have seen patients with, same behavioral difficulties post TBI, and they were depressed, and they responded very well to the TMS. So that was from the neuromodulation side.
Thank you. So as you probably have gathered, at Buddhi Clinic, we have a rather multimodal approach to care. And apart from physical, psychological, and holistic rehabilitation, we also have a very active neuromodulation service that's making a difference for a lot of people. Mr. R is, I believe, with us, and I'm going to invite him to share his experience if he's available to do that.
I'm just checking it, sir.
Yeah, please. So we have a lot of other questions. So maybe I'll keep talking to Dr. Neeraj Agarwal and taking his expertise rather than lose the time.
Am I audible?
Yes, Mr. R. Please go ahead and tell us how you're doing now and your journey to getting better.
Okay, thank you. Thank you for inviting me to give me my experience, give you all my experience with the whole progress, I would say. So yes, I think all of you has really portrayed the scenario really well. And I have to say, this is the first time I'm hearing about myself. And it's really interesting to know what exactly has happened to me from the actual experts who has actually dealt with me and sorted the whole thing for me in this new era for me. So what I would say, so there are majority of the things from the moment that the incident happened until like early this year, 2020. So around 6 months, my memory was not that great at all. For the first 4 months, I do not have any memory, I would say. And then probably in the last couple of months in November, December, I had got reasonable amount of memory that could help, getting my state to a better one. My experience was amazing. So I would say, like, rather I would start from like where I started November, December, which is what I remember, to be honest. So I was able to see the transformation. So I was able to understand, I was able to see who is the person coming to my home, who's sitting next to me. I was able to identify them. Well, to be honest, I don't know my mom, I don't know my dad, I don't know my wife. I couldn't recognize them in the initial stages. So they said that to me so many times that I have never recognized them. And I've called them by different names, and I've, probably they have been like, not even my relatives. My cousins came to my home to see me, and my friends came to my home to see me, and I'm unable to recognize them, but I was able to talk with them all the past incidents that I had with them. That's a bit strange. So I was able to remember something well before the incident, but I was not able to remember them for that moment. However, after November, December, this slowly got interesting and was improving. And my wife and my parents, they were helping me to get better. And yes, they put me actually in November, December, they actually took me to my office as well. I came to have a little bit of history on what I was doing. So I came from UK, I was doing some work here. I came here to do a startup for 2-3 months, and I went for a trip with my friends. And when I came back, and this incident happened. So after this recovery period from July, August, when all the Buddhi Clinic experts were working on me, I was able to recover reasonably well, and I was able to go back to my office, and I was able to recognize all my colleagues. My colleagues were very interested in my presence there, and they were like really happy. They wanted me to get on board with them. I was a little bit surprised, not really by then, by now actually. They asked me to actually carry on with the thing that I was doing a month before the incident. I was able to go back and talk with my clients, and was able to get back on the job straight away in November, December. That was really surprising for them because they didn't expect that. It's really interesting. Since then, I've been improving a lot. So I like the TDCS RTMS Vivek said told, and all the other therapists, all the other therapists, like very interesting. All the Ayurvedic, Ayurvedic therapies, this like acupuncture, acupressure, meridian massage. So it was really great for me. So I think all the things actually in a package has helped me. And I have come to a great extent. I have come a lot far.
Thank you for sharing your story, and incredibly brave of you. And we are also happy that you've done so well. A question to you is, you've actually now in the last 6 months, you've developed a whole new product/platform. Am I right?
Yeah, that's right. So what actually happened is like, I came for a purpose to India. And I was trying to start that business. So, and then it immediately happened. The incident immediately happened. So everything got postponed. But December, I was able to start the job again, this 2019 December. And from there to 6 months, I was able to complete the first vision, because being in the products for a long time, I was able to build the product with artificial intelligence and machine learning, which is my core. Which probably needs a lot of brain work. So my brain is now fully cognizant. It's really, really, the work I do is compute intensive. I know that I lack a little bit of memory, which I'm sure that I will work with Vivek sir to get that ready to a better extent. But yes, I was able to actually create what I came for here. So I was able to create the business, and we are into the market, and I'm dealing with the real market at this situation. So at this moment, and it's going really well, sir.
So kudos to you, and compliments to your family for your wife and your parents for sticking with you and working so hard with you to get you to this point. And I think all of us are really happy for you, Mr. R. Thank you so much for joining us and sharing your story. It's really nice of you to do that.
Absolutely. Thank you so much. And thank you for making my parents and my wife's experience really, really better, because my wife is, I just got married. Like, I'm with her for only 2 years now. So she's been really brave with me, and she was like consistently helping me and make sure that I'm here right now. So with you all guys speaking in, thank you so much. And I'm sure that, my parents used to say, they used to tell, they believe in God a lot. God has helped. And I'm sure that God has in some version has come, and Buddhi Clinic's experts making sure that I'm right here today.
Thank you so much. Dr. Agrawal, would you like to give us your feedback about his story and how you find him compared to the story you heard about how he was when he came in?
I think he's done extremely well, and I'm really pleased to hear the story. And I think that's credit to not only Mr. R's and his family's involvement in his work, but I think all the clinicians at Buddhi Clinic. I think the treatment you've offered sounds to me it was second to none, and I think it's the overall. I think it highlights how a number of different elements, some of them at different stages, initial very significant neurosurgical input to later on more therapy input, and then whole range of holistic treatment to psychological changes of medication to neuromodulation. So I think that highlights the whole range of spectrum of treatment that is needed in the aftermath of brain injury.
Thank you. And I think it gives us hope that with multimodal work, we should be able to help patients recover well from brain injury. And it's so nice to hear him talk about, getting back to normality, recognizing that things were not all right at some point in time, but now I'm better. It's wonderful from a human perspective.
And I think what we don't hear in this story is what happens if you don't have that kind of input. And unfortunately, there are a number of places all over the world. There are a number of places in India where there will be very few places in India where they would have this kind of range of treatment that is available at your clinic. We don't get to hear stories about what happens if you don't have it. But from my experience, the outcomes are a lot poorer.
Thank you. We've got a few questions in the chat box, but I think it's an opportunity for some people to put up their hands and ask a question. So if you put up your hands, we'll unmute you, and we'd love to hear from you, all those of you in the dialogue. So we have a hand up from Dr. Chokalingam. Can we unmute Dr. Chokalingam, please, Vivek?
I can start the
yes,
video,
sir, please.
Video.
They'll do that also, sir. Please go ahead.
Hello, Dr. Chokalingam. I think we met when I visited.
I really appreciate ESK and Agrawal. I came a little late. I mean, despite the COVID-1, how ESK is connecting people is really marvelous. Greatest appreciation, Krishnamurthy. And your approach is really great. I got one or two comments. I want to know the answer also from that. Now, you have been telling about the physical trauma. How often that effect of mental trauma for the individual will be having the same behavioral changes like that, because mental trauma sometimes will be having a lot of disarrangements of the neurological function. What is that comment from Agarwal? 1, 2 is the helmet wearing really saving people? I really don't know, but I believe that maybe myth what they are doing it, maybe. What is the real statistics, Krishnamurthy and Agarwal, the helmet wearing, without, with, how it is? And third one I want to ask you, Agarwal and Krishnamurthy, heart muscle can withstand the absence of blood supply up to 15 minutes, 16 minutes, or even 18 minutes of the arrest, we can revive them. What exactly recovery time for the brain if it is deprived of blood supply? Is it 2 minutes, 3 minutes, or when does it permanent damage occurs? As a cardiologist, I'm asking Agarwal.
I must try
Thank you, sir.
I'll start from the very first one. You mentioned about psychological reactions. And I think that's a very, very important element of clinical presentation. That could range from, as I mentioned earlier, a serious post-traumatic stress disorder, acute stress reaction, where particularly if somebody domestic violence we heard earlier, or assault, depending on the circumstances, it could be very seriously traumatic, resulting in very significant symptoms. But afterwards, all sorts of psychological reactions, which are in relation to either difficulties in relationship, losing work, having financial troubles, and day-to-day frustrations about all the symptoms can affect mood. People can become depressed, people can be highly anxious, they can lose sleep, they can lose motivation, they can disengage with therapy, which becomes quite detrimental. So psychological reactions are a very important element. And many of the symptoms could be very similar to symptoms of brain injury. And actually what happens is two things combined together makes the presentation even worse. So we have to deal with both sides. We have to deal with the actual effect of the brain injury, but also the psychological reactions. So I guess that's the first part of the question. The second question, was that about helmet? I think you asked a question about helmet. Helmet is an interesting story, and helmet story is evolving because helmets are evolving. So helmets are definitely useful. They would prevent impact injury. They would prevent scalp injury. They would significantly reduce chances of skull fractures. They would also reduce the forces, because the newer helmets, they absorb lots of energy during the impact. So the actual energy transferred as a consequence of impact to the brain is massively reduced. But what it doesn't prevent is some of the other mechanisms of injury, which includes rotational forces. So head could suddenly move sideways. It does not prevent acceleration, deceleration injury. So car is traveling very fast, or if you're falling, we are coming with a very significant speed, and suddenly there is impact leads on to stop, but pain inside continues to travel and impacts against the skull. So, I earlier talked about the relative consistency of the white and gray matter, resulting in shearing stresses. So helmet probably reduces some of these elements, but does not take away completely some of these elements. But still, I think it's very important. Helmet does reduce the brain injury and its consequences.
And the blood, the third question was, how long can the brain manage without blood supply as compared to the heart, which professor says can go on for 15 minutes, even 18 minutes.
Absolutely. I think probably brain, I think if you look at the stroke studies, and we earlier talked about that critical period, people have talked about thrombolysis being useful up to 4 hours. But I guess as the time goes on, it becomes less and less effective. So I know our hyperacute stroke unit, they did an audit, presented it last year, and they talked about door to needle time. So as the patient arrives in A&E department to the time they actually get the thrombolysis was about 25 to 28 minutes. So they try and do it as fast as they can, but certainly I think thrombolysis they would refuse to do because the risk increases of bleeding if they do thrombolysis beyond initial 4 hours.
Thank you. We have 2 hands up again, Vipin Chandramani and Vandana Chandramani. Can we unmute them, please?
Hi, can you hear me?
Hi. Yeah, please, go ahead.
Okay, I suffered, a TBI in 2014. Diffuse axonal injury, and I had a stroke, and I was having many problems with majority of problems with depression and sleep, And right now I was on a doctor. I'm from Jamaica, by the way, in the Caribbean. And the doctor, she is a prominent psychiatrist here in Jamaica, and she prescribed me Ambien. And I was on Ambien for maybe about 8-9 months, every single day. And then the chief medical officer of Jamaica, the head of medicine, actually the doctor who brought Ambien to Jamaica or introduced it to Jamaica, he immediately took me off. he says you shouldn't be on a medicine like this for your sleep for so long, because Ambien is a very addictive medicine. And what happened is, now I went to another doctor, and then he prescribed me, and he was prescribing me first. He prescribed me Paxil, paroxetine, and then he changed this to Seroquel, because he thought I had maybe some other issues. And then the Seroquel wasn't working with my body well, and my family and we came to a decision to just discontinue this. And then I decided, I'm currently on venlafaxine, and the quality of my sleep is better. But what I really want to ask you guys is, Dr. Agarwal, he said he was saying about the newer approach with psychostimulation. So could I get some examples of these medicines, and maybe I could just do some more reading into it, please?
Mr. Chandramani, thank you for sharing your experience. And I think, again, you're highlighting how people can be left with persistent emotional and behavioral problems after brain injury. I think it's very hard to give a very meaningful, individualized treatment advice on a forum like that, because we only know so much about you. And whilst I talked about stimulation, psychostimulants being used, they're used for very specific reasons. And I doubt the kind of symptoms you have described, they could be helped by those kind of medications. So, I think I don't want you to get that impression that psychostimulant would be the best possible treatment for you. I don't think they are relevant for your care based on what you have described.
And maybe I should add that I have not mentioned it, but if you're not receiving therapies and rehabilitation, physical therapy, psychological therapy, I would definitely look for those kind of support services in addition to the medication. Neeraj.
Absolutely. Yeah, no, I couldn't agree more.
I'm just going to go back to some more questions on the chat, Dr. Agarwal. There's a question about frontal lobe syndrome from Dr. Praveen Kumar. And is there a preference among antipsychotics for managing the behavioral issues post-head injury?
Again, a very good question. So we see lots of people with what used to be called frontal lobe syndromes. We don't tend to use that kind of terminology now as often, but I know what you're talking about because we used to use that terminology ourselves. I think people have used words like agitation or aggression or personality and behavioral changes after the brain injury. I think it depends really, I think my clinical experience is, okay, before I go on clinical experience, we did a randomized control trial. So if you look at, there are very few randomized control trials or specific treatment recommendations for these symptoms. There have been a number of guidelines. There have been a French guideline, there's a North American guideline, rehabilitation guidelines from BSRM, but they're not based on very solid research evidence. My clinical experience is we look at 3 different elements of those behavioral problems. So some people, they have kind of symptom profile where they have emotional lability, impulsivity, and they are becoming irritable and angry as a part of quite a lot of fluctuations in their emotions. And those people tend to benefit from mood stabilizers. We use quite often things like valproate or carbamazepine, but there are a number of others that can be used. There are then people who have just explosive anger, kind of, they just blow their fuse and they become very irritable and angry. And they kind of find it very hard to control their behavior. And so those kind of people benefit from atypical neuroleptics or atypical antipsychotics. We use medications like risperidone or quetiapine, Some people use olanzapine for more severe end, but we try and avoid that because olanzapine is quite sedative and can affect negatively the neurocognitive functions. And then there is a third group of people who are particularly in inpatient kind of setting, but that applies equally at home as well, who are just wandering around aimlessly. So they can't sit still, they walk around, they fiddle around with things. They often want to leave the places. They kind of very restless. And those are the people who could benefit from beta blockers. So there have been Cochrane's trials. So in fact, the largest study, 3 randomized controlled trials, and a Cochrane review concluded that propranolol and other beta blockers could be useful in high doses. But those people have more like akathisia-like presentation. They are restless, they're moving around. And a number of specialists working in this field would know what I mean when I say akathisia, where people are restless, they can't sit still. So some people after brain injury, even without using any neuroleptics, have that kind of presentation. And I think I like to try and get a good mental picture of which of these 3 categories the agitation fits in. And based on that, I would be pointing my first protocol towards managing these.
Thank you so much. I think your experience is so well brought out in describing those 3 groups of people you treat. There's a very relevant question, since we live in the COVID era, from Dr. Jyoti Shetty. She wants to know, with regard to TBI plus COVID, the neuropsychological rehabilitation and the challenges. Would you like to comment? Have you come across patients with the dual diagnosis, and what are the challenges, and what do you anticipate?
I think we'll be probably coming across more of these people in the future. But interestingly, and I'll try and answer that question. So interestingly, a Lancet study, which was published in May, which is a UK-wide surveillance study of neurological and neuropsychiatric manifestation, had more than 150 patients. And the commonest neurological condition was some kind of cerebrovascular event, both hemorrhagic and ischemic. They also had people who were presenting with confusional states, and neuropsychiatrically, the manifestations included fatigue, depression, and cognitive decline, almost like dementia. So these are the kind of manifestations which are caused by direct impact of COVID-19 on the brain. And if we can clearly see, if we combine any of these things with a significant brain injury, then we are looking for a lot more significant problem. And I wouldn't be surprised, statistically, number of people in hospital settings who have come in with brain injury, like any of us, would be susceptible to have coronavirus, and they could develop an infection. And if they have significant infection, then it could be quite challenging to manage.
Thank you. I think that's it is something that one needs to be so aware of. Phillips Anthony asks a question: when does psychosocial rehabilitation start for Mr. R? And I think Dr. Agarwal will back me when I say that psychosocial work with the family has to start on day 1. And psychosocial work with the individual starts as soon as it's possible, and as soon as it's one is able to do it, for the simple reason that the individual has to be somewhat awake and cooperative for us to do that kind of work. But I think one of the most difficult things with traumatic brain injury is for families. Often families can be young, families may or may not have the support system. The person who's injured may be the most important earning member of the family. There's a whole future at stake. And there's a sudden change in the person's disposition and behavior, which families find extremely difficult to understand. Why is this person I knew suddenly so aggressive, or suddenly so disturbed, or suddenly so depressed? And I'm going to ask you for those final words, Dr. Agarwal. isn't it very important we also work with families?
Family work is extremely important. And what I find is quite often people struggle to understand the whole range of consequences of brain injury. It's not natural to any of us to recognize, and particularly once people have shown initial physical recovery, there is no wound to be seen. You know, their wounds have healed, any external physical wounds. They have come out of hospital, they are back at home. They might be having whole range of, they may not remember, you know, wife says, have you done this? Or could you please do that? They've forgotten, or they are getting irritable or angry, or they're not sleeping, they're looking tired. Quite often people, you know, say, well, come on, you know, your injury was 6 months ago or a year ago. Come on, get on with it. So, and it could lead on to arguments. It could lead on to greater difficulties. It can lead on to breakdown in relationships. So I think working with family to help them understand, but also help them learn strategies. What is the best strategy to deal with? If somebody is getting really agitated in front of you, they can't control their emotions. What do you do to help them? So from both the sides, their own understanding as well as what they can do to help the patient is very, very important.
Thank you. And I think with that, we should be calling this to a close. We've been at it for 90 minutes or more. I'd like to thank you, Dr. Neeraj Agarwal, for taking the time to enlighten us about traumatic brain injury and behavior. It's been wonderful listening to you. I'd like to thank my colleagues from Buddhi Clinic for presenting Mr. R so well. I'd like to thank Mr. R for having the courage and gumption to come on the program and talk to us. And I think we've had a very attentive audience of people, a very attentive and active audience of people who stayed with us right through the dialogue. And we'd like to thank all of you for being here today on Vinayak Chaturthi to talk about brain injury. If you have any questions, I'd request you to, please email care@buddhiclinic.com, and we'd be very happy to answer those questions for you. And if you'd like any specific things asked from Dr. Agarwal, we would forward those queries to him on your behalf as well. And I'm sure he'll take a few minutes to give you some answers. Final words, Dr. Agarwal.
Thank you very much. Thank you very much for this very nice forum. I think it was very nice to hear, you know, the good work you've been doing at Buddhi Clinic, and good to hear Mr. R's story, which is very inspiring, and it fills me with lots of hope about good things are being done in India. So thank you very much for having me here.
Thank you so much, Dr. Agarwal. Thank you so much, everyone.
Thank you.
Have a great evening.
Thank you.